Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Welcome everyone to the auditorium. This is our clinical pathological conference conducted by the hand team from the orthopedics department. Okay, so our topic today is an electrical lump in my forearm. Now, when you hear this title, I hope it evokes some sort of curiosity inside you, because an electrical sensation inside a limb might sound fantastical or might sound magical, but then there are actually cases or patients that you might see on a daily basis in your medical practice in the future. Okay, so the presenters for today will be from the hand team. Dr. Adli, my colleague, and myself, I am Danial. And we have our special guest today from radiology and also pathology, which are Dr. Juliana and Dr. Badrul Iskandar, who is the anatomic pathology medical officer over there. And we are joined by our anatomic pathologist, Dr. Wan Shahira, sitting next to him. And of course, we also have the hand unit here, which is headed by Prof. Dr. Shalima Abdullah. If you don't know her, there's something wrong with you. All right, okay. And of course, our Prof. Madia, Dr. Jamari, who can't be joining us today because of work commitments. But we have Mr. Paminda, very popular with all the students, and Miss Elaine, the lovely Miss Elaine. And we also have Mr. Colin, who's a fellow from UPM. Okay. All right, so to proceed with our presentation, I'd like to invite Dr. Adli to the stage. Please welcome Dr. Adli.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning. I am Dr. Muhammad Adli. He's a medical officer from Ortopedik Department. Currently, I am at a hand unit. So we start with the history of the patient. Okay, Miss A, 34-year-old lady with right hand dominant. She is a staff nurse. She was presented to us with 3 years history of swelling of the right forearm. The swelling is slow growing, and it was associated with the electrical-like pain, which is radiating from the lump towards the fingers, and also numbness of the fingers for 3 years. And it was affecting her work and daily activities, especially want to carry the handbag of the right forearm. Okay. Otherwise, there was no rest pain, no neck pain, and no constitutional symptom. We move on to examination. As you can see in the picture, the site of the lump, the swelling is located at the volar aspect of the mid forearm with size around 5 × 3 × 2 centimeter here. Okay, the shape is oval in shape. The surface was smooth. However, there was no prominent vein, there was no scar or no stigmata of neurocognitive disease such as Kefir outlet. On palpation, the area of the swelling is non-tender and not even warm. The consistency is firm and is not mobile actually upon flexion of the finger at distal interphalangeal joint or proximal interphalangeal joint. There was no palpable thrill, no slip sign. However, the tinel sign was positive. Upon neurological examination of the peripheral nerve, on the median nerve, the power of thumb abductions, thumb flexion and opposition were full, 5/5. However, the sensation of the tip of the index finger on light touch was reduced. On the ulnar nerve, the finger abduction and finger adduction was full, and the little finger sensation was intact. While radial nerve, the wrist extension and finger flexion were full, and dorsal first wet space sensation was intact. Okay, at this stage, we already came out with several differential diagnoses with the clinical history and also examination. The differential diagnosis can be divided into two at this stage, which is benign and also malignant. As for benign, it can arise from the Schwann cell of the nerve, known as schwannoma, while it can also arise from multiple type of cell in the nerve, known as neurofibroma, or even from the adipose tissue, which is lipoma. If it's malignant, it will possibility of a malignant peripheral nerve sheath tumor derived from the nerve cell. Okay, the point that supporting the benign cause of the tumor, which is schwannoma and neurofibroma, in this case is the positive retinal signs, and also the tumor was slow growing and no constitutional symptom. However, the point again is because the size of the tumor is roughly about 5 centimeter, so the malignancy must be excluded. For malignant peripheral nerve sheath tumor, the point that support this diagnosis is because it's large, okay, more than 5 centimeter. It's about 5 centimeter, and the tinal sign is positive, means it came from the nerve origin. However, the point again is patient doesn't have any constitutional symptom, and it was slow growing. So the few investigation must be done, must be carried out to rule out all these possible diagnoses at this stage. Okay, it include the imaging technique, which is included plain X-ray, ultrasound, and as well as MRI. Okay, now I would like to invite Dr. Juliana Fairuz as a musculoskeletal radiologist to further describe about the radiological findings.
Assalamualaikum and a very good morning to everyone. Thank you, Dr. Adli. So we are going to move on with the radiological perspective of an electrical lump in my hand. So I'm Dr. Juliana. So the content of my presentation today, we are going to look back on the clinical presentation, the images being done for this patient, the differential diagnosis, imaging modalities available, and the overview. So in this picture here, we are pointing to you the tinal sign positive for this patient. Again, the patient is young. She came in with swelling and lump. This is an X-ray of this patient. So what do we look for when we see an X-ray? So we have to look for calcification. We have to look for phlebolith. With this present, there is a few of differential diagnoses that we need to bear in mind. In this case, you can see zoom in to the oval area at the mid forearm region. There is no such of lesion. There is no calcification there. Is there any bony lesion or extension of the lump? There is none. We are only seeing an oval shaped soft tissue opacity here without any of the above described. Then this patient is subjected for an ultrasound. We are having this description for every ultrasound. Bear in mind, hyperechogenic is a bit denser or opaque. The anechoic is pointing towards fluid, and hypoechoic is more towards tumor or solid tumors. In this patient, we have a right volar forearm lesion, which is a bit heterogeneously hyperechoic. The widest dimension will be 4.3, almost 5 centimeter. And is located at the right volar forearm region. And in not depicted in the image, the vascularity, it has minimal intralesional vascularity, and there is no other lesion found in the forearm. And this patient also subjected into MRI. So in this MRI, you can see on the left hand side, this is your T1 axial, is good for anatomy. And in this patient, it has this homogeneous signal, right? You can appreciate that there is a high ISO to hyperintense signal of this lesion. On T2, this is your typical target sign. You have a central hypointense signal within, you have peripheral hyperintense signal at the periphery. On T1 coronal, you are having your split fat sign. This is very typical. It displays the intramuscular fat within the intramuscular location, and this target sign as well as split fat sign is also the normal appearance of a neurogenic tumor. We subjected this patient for contrast study, and it shows homogeneous enhancement to the lesion. There is no perilesional edema, there is no infiltrative nature of this lesion. It looks benign on the MRI. So our differential at this time would be a neurogenic tumor, likely benign. It could be your schwannoma or your neurofibroma. So let's look at the radiological differential diagnosis. We have two, which is the nerve in origin and non-nerve in origin. Like I mentioned before, the benign nerve sheath, peripheral nerve sheath tumor. You have also your rare ones, which is your intraneural lipoma, perineurioma, and your MPNST, the malignant type. For non-nerve in origin, we have your lymph node and vascular malformation. We will look at these pictures later. All right. So number one would be your benign nerve sheath tumor. Okay. So neurofibroma would be your having your target sign. But in this particular case, this is an ankle of not a target sign. This is more towards fascicular sign, where you can see a bit of the hyperintensity where it is more centrally located, right? So this is your fascicular sign. Another findings for a neurogenic tumor. In this patient, this is the schwannoma of the knee, sorry. So this patient also have this target sign. However, the target sign is more eccentrically located, and this hypointense signal at the posterior back here, it signifies the calcification. So for schwannoma, it tends to have all your neurogenic tumor finding as well, with addition of having a cystic component, hemorrhagic component, it could have calcification, and these features mimics an MPNST. Okay. All right, this is a rare case. Just wanted to show you that you can also have this information if you are doing an MRI. This is the case of perineurioma of the sacral plexus. You can see the fascicle is very enlarged and enhancing. And in this case, in intraneural lipomatosis, normally is very rare. It is associated with macrodystrophia lipomatosa, where it has this lipomatous lesion, which signifies an coaxial appearance on this sagittal, where you can see the fascicles is well dispersed, intervening with the fat component. All right, so just wanted to show you this busy slide of benign versus malignant. So as mentioned just now, the benign would be lesser than 5 centimeter. It looks benign, it has this well-defined margin, and the neurogenic signs is well described here. But for malignant type, you have larger dimension, more than 5 centimeter. Normally, indeed, it has this peripheral enhancement, very exuberant peripheral enhancement. You have perilesional edema. You can have cystic component, or we call it as necrotic component within. And on T1, it shouldn't have homogeneous. It could represent as heterogeneity on T1, which signifies it has a hemorrhagic component. So these are the MPNST features. In advanced imaging, if there is available, we can do a PET scan, we can do a functional MRI. But for this patient, we subject this patient for a biopsy. For the non-neuro origin, this is your ultrasound image of a lymph node, also can be mistakenly as a neurogenic tumor as well. But you can see here at the central, there is fatty component here, and you have a hypoaccurate region here. And if we on the Doppler, the fatty tissue should have a vascularity because it is a fatty hilum in the lymph nodes. So this is a reactive lymph node. For vascular malformation, like I mentioned before, on X-ray, we could appreciate the phlebolith. And in this case, you have few phleboliths here. If you find one, think of vascular malformation. Subject this patient for an MRI, it homogeneously enhances. There is a phlebolith at the curved arrow here. And on ultrasound, definitely we are appreciating more information, which we denote by this intralesional vascularity. Okay. So imaging modalities for a soft tissue lump with thinner side, we have X-rays, we have ultrasound, and we have MRI. Easily available for X-ray and ultrasound, especially in our center as well. MRI is very good to evaluate further to get the soft tissue differentiation and as well as local staging. In advanced cases, we have to subject this patient for PET scan and advanced MRI. Okay, so next, what is the goal for biopsy, or is it indicated to have a biopsy? Definitely, like I mentioned before, it's not 100% for radiological to give the diagnosis of benign. It could may represent something malignant, such as if we find something like perilesional edema. So in suspicious cases or indeterminate lesion, we should subject this patient for a biopsy. But there is also risk for a post-biopsy pain. Then you have to counsel the patient for the pain after the biopsy. But risk versus benefits, yeah? Okay. So the summary for this patient. So definitely, like I mentioned before, in indeterminate lesion, we are unable to really be very, very sure. In suspicious lesion, we should subject for this patient for a biopsy. And biopsy also has this inherent risk. But if there is imaging of a benign features and the MRI concurs with the benign region, we should wait and see the lesion whether it is having a suspicious lesion after a follow-up imaging is being done. And with that, thank you so much.
Okay, thank you, Dr. Ju, for the brief explanation about the radiologist. Now, the next step of the investigation that we do for this patient is ultrasound guided biopsy. Okay, the biopsy was obtained through the ultrasound guided. It was important to, like Dr. Ju mentioned before this, to differentiate between benign and also malignant tumor. And it's also important to distinguish between, in this case, to distinguish between schwannoma and also neurofibroma, because the approach of the management is different in each pathology. Such as in this slide where I show here, the schwannoma, it can be either treated conservatively or we go for surgically with the enucleation of the tumor, which is we remove the part of the tumor with the nerve preservation. While in neurofibroma, apart from conservative, we might need a surgery with removal of the tumor together part of the nerve. So the nerve grafting might be necessary in this type of case. In malignant, the main principle of management mainly is surgery, which is wide local excision. Remove the entire block of the nerve together about 2 centimeter, the normal cuff of the normal tissue. And patient also might have amputation if the tumor is invasive. Okay, and apart from that, radiotherapy also necessary as an adjuvant. So, and the final result of the biopsy in this case, we find out patient to have a schwannoma, and as you can see, in this case, multidisciplinary approach is very important to arrive with the working diagnosis of schwannoma. It includes the orthopedic team as well as the radiologists and also pathologists. So our professional diagnosis at this stage is schwannoma of the right upper limb, mainly which is from median nerve. So the management of the schwannoma, like I said before, can be divided into conservative or surgery. For conservative, we can advise patient to continuous monitoring of the progression of the tumor. If there is any neurological worsening of neurological deficit or any new neurological findings, and also monitor if any sign of malignant transformation, such as rapid growing of the tumor, sudden onset of pain, or any considerable symptom, so we might need to consider surgery. But if proceed with the surgery, we might need to warn the patient regarding possibility of the nerve injury during the surgery, and that can cause any temporary or permanent neurological deficit later on. So the final decision by patient in this case, after further discussion with the patient, patient keen for removal of the lump due to symptom of the numbness that she have, and also feeling discomfort over the forearm, especially during lifting a handbag just now. Now we move on to the surgical treatment of schwannoma. Okay, this is an intraoperatively picture of this case. There was a yellowish firm mass over the volar aspect with a range measuring about 4 times 1.5 centimeter, and is located underneath the FCR muscle. As you can see here, we retract the FCR, which is flexor carpi radialis muscle, medially to expose the lump, and the median nerve was playing over on top of the lesion here. This is the lesion, and the median nerve come from proximally and go on top of the lump. So we open and remove only the lump. And we found out there was also thinning of the median nerve at the site of lesion, possible due to compression. So after we remove, this is the actual picture of the schwannoma. We're measuring about 4 times 1.5 centimeter, and it's like a oval in shape. Immediate post-operatively, patient complained of worsening of the numbness over the radial 3/2 of the fingers. And upon examination of the sensation with the pinprick and also light touch, there was a reduced sensation over the median nerve distribution. But however, the power of the thumb, abduction, flexion, and opposition remained full. And we advise patient to monitor the symptom first. And while patient was discharged with antibiotics, cefuroxime, analgesic, Celebrex, and also neurobion. And 3 months follow-up, patient claimed the symptom of numbness was completely resolved. And upon examination, the sensation with pinprick and light touch, the sensation was fully recovered and was intact. The power remained full. Now I would like to invite Dr. Badrul to the stage for histopathological discussion for the biopsy.
Okay, Assalamualaikum and good morning everyone. My name is Badrul. I'm from Pathology Department together with my specialist, Dr. Wan Shahira. So I will present regarding the histopathological findings for this case. So we received a specimen labeled as tissue at the right forearm. It is a tan whitish tissue measuring about 48 times 13 times 10 mm. The outer surface of the tissue appears smooth and glistening, and serial cut section shows a well-circumscribed, homogeneous tan creamy cut surface. There is no necrosis or hemorrhagic scenes. So with regards to the microscopic examinations, you can see there is a well-circumscribed and unencapsulated lesions, okay, well-circumscribed lesion, which is composed of biphasic cellular pattern. So this is what I meant by biphasic cellular pattern. You can see there is presence of antennae A and antennae B. So antennae A basically is a hypercellular areas. Okay, another areas of antennae A over here. And there is also hypocellular area, or we call it as an antennae B, which is over here. And also over here. On further magnifications, another pictures of biphasic cellular pattern. You can see on the right side is the antennae A, and also on the left side is the antennae B. Basically, there is a spindle cell elongated proliferations, which in antennae A, it is embedded within the collagen fibers. However, in antennae B, basically, it is sparsely cellular as compared to antennae A, and it is embedded within the loose myxoid stroma. So within the hypercellular area, you can see there is presence of verrucate bodies. So what is actually verrucate bodies? Verrucate bodies is actually a pattern where you can see there is a nuclear palisades with the adjacent areas of anuclear zones. So for example, in this case, you can see there is a nuclear palisading over here with adjacent anuclear zones, and then another nuclear palisading. Another example is in like in the 6 o'clock in the pictures. You can see a nuclear palisading, a nuclear zone, and another nuclear palisading. So this is the higher magnification showing a nuclear palisading. So this is what we call it as a verrucate bodies. So with regards to the immunohistochemical stainings, in case of schwannoma, S100 will be positive. S100 is actually a Schwann cells markers. So in case of schwannomas, it will be diffusely positive and highlighted the Schwann cells. But just want to inform you guys that schwannoma basically is a morphological diagnosis, means that by doing a routine H&E staining, we already can conclude schwannoma by the presence of biphasic cellular pattern with verrucate bodies. However, in cases that not atypical schwannomas, S100 staining might be useful. So the main differential diagnosis for schwannoma is a neurofibroma, which is it is another entity of benign peripheral nerve sheath tumor. So histologically, what are the differences between schwannoma and neurofibroma? First, in schwannoma, usually most of the cases is encapsulated. However, some of the cases it also can be unencapsulated. However, in neurofibroma, usually it is unencapsulated. And in schwannoma, histologically, usually there is a biphasic cellular pattern, which I already mentioned just now. There is presence of hypercellular and hypocellular areas with the presence of verrucate bodies. However, in neurofibroma, usually there is no antennae A and then no antennae B areas, just a diffuse fascicles and holes of spindle elongated cells embedded within the wavy collagen fibers. So I think that's all from me. Thank you.
Okay, thank you, Dr. Badrul, for the discussion on the pathology side. So I'd like to move on to the case discussion, which we will discuss regarding controversies and also other pertinent issues that we would like to address with the patient. But firstly, I would like to compare and contrast the different peripheral nerve sheath tumors, and this is more for you guys memory aid lah. Yeah? So for the tumor origin of the nerve sheath tumors, you would have Schwann cells only in schwannoma, but a neurofibroma could originate from Schwann cells, perineural cells, fibroblasts. Okay, I repeat again, multiple cells, Schwann cells, perineural cells, fibroblasts. This is important because later on we will have a quiz. So, and then MPNST, we have Schwann cells and perineural cells as well. Yeah? So schwannoma, Schwann cells only. The rest, multiple cells. Okay, regarding the benign or malignant nature, for the three types of peripheral nerve sheath tumors, schwannomas would mostly be benign. Yeah? Very, very extremely rarely have malignant transformation. Neurofibroma has a 5% malignant transformation, so we can say it's usually benign. MPNST, by nature of the name itself, it is malignant. Yeah? So gross appearance, we would like to mention that schwannomas would be eccentrically located in relation to the nerve, like this. Yeah? Okay, and normally orthopedic surgeons like to use the word splaying of the nerve. So what splaying is basically if you imagine a strand of rope, yeah, where it unwinds and also separates. Yeah, so that is splaying. Yeah, because the nerve would actually push the fascicles away from the nerve center. As opposed to neurofibroma and MPNST, they would be more centrally located and they would encase the fascicles and would involve a lot of different fascicles. As opposed to schwannoma, schwannoma might involve one or two fascicles, very, very minimal involvement of the fascicles. Clinical presentation, schwannoma would be slow growing, it would be painless, it could have paresthesia, but it's usually not painful. It usually doesn't cause any motor deficit. Yeah? And it's usually solitary. Yeah? As opposed to neurofibroma, it has a variable presentation. You might find multiple lumps, but they are often asymptomatic. But as I said, it could be variable. Yeah? But MPNST, very, very specifically, rapidly growing soft tissue mass. There is pain. There is definitely neurological deficit. Yeah, and when we talk about nerve sheath tumors, we would have to mention about neurofibromatosis. So I'd like you to go back and read about neurofibromatosis, but basically there are two types. Yeah? For schwannoma, it is usually associated with NF2, neurofibromatosis type 2. But neurofibroma and MPNST is commonly associated with neurofibromatosis type 1 or NF1. Okay, next is the histopathological features, just to compare and contrast. Schwannoma, antennae A, antennae B, and verrucate bodies. And I'm sure that you've heard the presentation by Dr. Badrul just now, what they are. Yeah? Neurofibroma is hypocellular, predominantly fibroblast containing, but they have elongated wavy nuclei and also a wire-like stroma. Whereas MPNST, spindle cells with marked pleomorphism. So I mean, all of these are buzzwords in case you encounter them in BAQs mainly. Increased mitosis and necrosis. MRI findings, actually schwannoma and neurofibroma have a lot of overlap with similar findings. Split fat sign, target sign, cystic in nature, eccentric lesion, and classification to specific for schwannoma. Tapi neurofibroma can also have this split fat sign, target sign, but it would be a more central lesion and it might not have classification. Whereas MPNST, due to the malignant nature of the tumor, it will have infiltrative growth pattern. It will have enlargement of a previously found benign nerve sheath tumor, and it will have perilesional edema. Okay, so why it is important to differentiate between these three lesions, even though they're basically peripheral nerve sheath tumors? It's because the surgical treatment, the further management, and also the prognosis is different. As mentioned by Dr. Adli just now, for schwannoma, we do a nerve-preserving surgery called enucleation, and this excision is basically parallel to the vesicles. For neurofibroma, we have to cut the nerve, but it's basically a marginal excision, where if we have significant amount of nerve loss, we would have to do a nerve graft. And for MPNST, you have to excise the entire nerve, a wide resection of the entire nerve with a normal tissue cuff surrounding it, 2 cm. And also we would have to proceed with radiotherapy, a neoadjuvant radiotherapy. So for the prognosis, schwannomas would have a favorable prognosis because it's benign, same as neurofibroma, but the recurrence rate, the schwannoma would have a lower recurrence rate, whereas a neurofibroma, it could have a slightly higher recurrence rate, could be variable as well. MPNST has a very poor prognosis with high mortality rate, high recurrence rate, and also it is highly metastatic. Okay, so this is to illustrate again the eccentric nature of the schwannoma, where it would actually arise adjacent to the nerve fiber, the nerve fiber, which contains the vesicles here, whereas the neurofibroma would be encasing all the nerve vesicles. So you cannot avoid cutting the nerve. Okay, as mentioned before, schwannomas are mostly, usually benign, but there is a very, very extremely small risk factor for malignant transformation. So the risk of malignant transformation, but then you would have to look out for these risk factors. A large tumor size, the rapid growth of tumor, especially in the first decade of life. It is highly associated with NF1. And usually people with NF1 has this thing called plexiform neurofibroma, so this is also a risk factor. Prior radiotherapy would also be a risk factor for malignant transformation. And actually, number 6 is something that is very new, because when we want to follow up patients with peripheral nerve sheath tumors, this new study suggests that we do routine ctDNA analysis to monitor, especially in NF1 patients, because if there are mutations to the NF1 and surrounding genes, then it is a risk factor for malignant transformation. Why it's important? Because if it's malignant, then you have to excise more, you might have to amputate as well. Okay, so we talked about the surgical treatment of our patient with schwannoma, which is we excise the schwannoma. But why do we do it? Number 1, because it is symptomatic. Number 2, because it is large. Even though the lesion is 4 point something cm, 4.3 cm, it's at the borderline, the cutoff point, because anything above 5 cm will be considered large. Or if it's rapid growth, like mentioned before this. And also because if it's too big, then it's difficult if we wait longer. Also, this patient's lump is at a very visible area, at the forearm. So there could be cosmetic concerns, especially to a lady. It's an aesthetically sensitive area, and we have to consider for excision despite being asymptomatic or despite the low risk. Another indication for which we don't have for this one is a suspicion of malignancy or diagnostic uncertainty, for which if we are really unsure about what it is, we need to have a tissue HPE analysis to guide our treatment decisions and also our prognosis. Right, so we've decided to do the excision, and we've decided that it's the best course of action. So we need to have a patient-centered discussion with the patient because there is a loss of nerve function post-surgery. And as I mentioned before, even though we do a lot of nerve-preserving techniques during the surgery, we want to minimize the loss of nerve function. But there is a potential risk of sensory deficit. And normally for surgery, we would have a neuropraxia. And if it's neuropraxia, then the loss of nerve function or loss of sensation or would be temporary. However, there is also risk of motor deficit if the surgery is more extensive, where we have to cut a bigger section of the nerve. So this motor deficit could also be neuropraxia if it's temporary, but then you have to remember about other more severe forms of nerve injury, axonotomesis and also neurotomesis. So this could be permanent. If it's neuropraxia, then there is good long-term functional recovery. But if it's axonotomesis or neurotomesis, then it could be permanent. So this is something that you have to be really clear about when you talk to the patient. You have to involve the patient. You have to talk about the risk and benefits. You have to make a risk and benefits analysis when you discuss with the patient regarding the surgery, because a lot of patients think that after you resect the nerve, her problems or their problems would disappear, but then they forget about what the risk involved. So clear communication from the start is very important. Okay, so I'd like to illustrate further regarding this surgery that we do. As you can see, this is a schwannoma which is encasing one nerve vesicle, as opposed to a neurofibroma that encases a lot of nerve vesicles. So at the end of it, when we cut, when we resect, this nerve vesicle obviously has to go, but sometimes it could even, be preserved. So it all depends intraoperatively. But a neurofibroma would definitely encase a lot of nerve vesicles and would therefore have to be excised. And in these cases, a nerve graft would be required. Okay, so I think that's the end of our presentation today. Take-home messages. Number one, numbness with electrical sensation usually would point to a nerve pathology. A functional loss, a neurological deficit, can be avoided with proper management and also, of course, proper diagnosis. Okay, a big lump, lump bigger than 5 centimeters, you would have to think about malignancy. And the last one is we need to have a shared decision making, because in the modern medicine practice, we do not dictate to the patient what we want to do. We discuss with the patients, we arrive at shared decisions, and this is vital between a surgeon or a physician with the patient. Shared decision making is very, very important. Okay, and with that, I thank you. That's the end of our presentation. I would like to open the Q&A session to anyone who has any queries. I'm expecting students. I'm expecting students from the orthopedic rotation to have some questions. Very good.
Okay, good morning to doctors. I have a question. What if the sensation doesn't come back or patient lose their motor function?
What if the sensation doesn't come back or the patient lose motor function? Okay, right. So as I mentioned before, thank you for the question. Right, okay. So if it doesn't come back, we have to think about when, the duration. So if it doesn't come back in 1 month, 2 months time, maybe we can still wait. Okay. If it, and also we have to think about, is it just sensory or sensory with motor? If the sensation doesn't come back, then we have to go back to our discussion, our patient-centered discussion, because this is actually a known risk for the surgery. The patient has to be prepared to lose that nerve function Yeah. If we have conducted the patient-centered discussion properly before, then we can say to the patient, okay, this is a known risk of the surgery. We would have to accept that loss of sensation. Because loss of sensation usually can be acceptable to patients. Okay, but if it's a motor function that's lost, then of course it's not going to be acceptable because the patient would lose function. So at this point, the team would have to consider further treatments to regain some function lah. For example, a tendon transfer. But this is in the future lah. Yeah? Usually we have a cutoff point of when to consider for nerve transfers. Does that answer your question? Okay, right. Prof, anything you want to add to that? Tak ada. Okay.
Sometimes for loss of sensation for peripheral nerve, you can have the surrounding dermatomes helping out. That means there will be some function. They're not going to be 100% back to normal, but maybe about 30% back to normal, maybe. So that's something that the patient may get. Okay.
Thank you, Prof. Yeah, I'm just gonna keep Prof here. Any other questions? Okay, any more? Any more questions?
Okay. Hello. My question is, if the patient doesn't want to do the surgery, how long can the patient keep the tumor? That's all. Thank you.
Okay. Right. So the patient wants conservative treatment, correct? Yeah, okay. And actually a lot of our patients are quite scared to have surgery. So that's understandable. Yeah. And if the patient is asymptomatic, the patient doesn't have any symptoms, I don't think there is any urgent indication to do the surgery. So you have to wait until there is an indication. What is the indication? The indication is neurological deficit. Yeah. So for example, the patient starting to have difference or a reduction in sensation, or worse, motor function, then of course at that point you cannot wait anymore. Yeah. So that is how long you wait. You wait until the patient has any symptoms. Okay. Any more questions? Or actually, I also have some questions to other. Oh, okay.
One more question.
Any more? Oh, okay.
May I know why do we need other radiological investigation and not straight to MRI?
Say again, sorry.
Why do we need other radiological investigation and not straight to the MRI?
Basically, why are we doing ultrasound, right? Why don't we be like a private center and straight away order MRI?
Very controversial question, yeah. But definitely in our center, we do an X-ray first. We want to see more information. You can see calcification fibrolymph. You can have other differentials. Not MRI. It can be very modern, very advanced, but we always go back to our basics. See the X-rays. Look for clues. See ultrasound. See intralesional vascularity is more depicted on these other imaging modalities apart from the MRI. So we do adjunct. We do complementary imaging to get a very confirmed diagnosis radiologically. Right? Thank you. Yes. So Prof wanted me to point it out that for AVM vascular malformation, the intralesional vascularity is more depicted on the ultrasound. So as I mentioned before, other imaging modalities help for us to give a better radiological diagnosis in the final end. So with X-rays, ultrasound easily available, so it can help us to give better diagnosis. Right? Okay, thank you.
Thank you very much, Dr. Juliana. Okay, now I have questions for you. Right, by show of hands. If the patient has numbness and also electrical sensation in their forearm, okay, how many of you think that it is a nerve pathology or a nerve tumor? Show of hands. I mean, that's the whole point of this. of this talk, right? Okay. How many of you don't think it's a nerve tumor and it could be another kind of tumor? Show of hand. Ada? Tak ada? Interesting. Okay. Any other questions before we... Actually, we have a quiz after this, for which the prize is bragging rights for the rest of the year. Itu je. Tak ada budget. Tak ada Okay. Right. I'm going to answer my own question just now. As I mentioned before in the take-home message, this electrical sensation or numbness points to a nerve pathology. Yes, it points to nerve pathology. So a nerve tumor is a nerve pathology. However, another kind of tumor, for example, a soft tissue tumor, other soft tissue tumors lah, myosarcoma, for example, in the FCR, could also compress the median nerve. So that would cause the same symptoms. So to answer my own questions, yes, it is nerve pathology, but it could be coming from other tumors as well, compressing on the nerve. Betul ke, Mr. Ferd? Okay. I would like to proceed with the Kahoot quiz. Betul ke, bro? Okay. So new info. The prize is having lunch with the hand team. Prof belanja. Yeah. Suka. Makan suka. Okay, alright. Yeah, can I ask the technical team to proceed with the Kahoot? Oh, so we're doing this on another platform called Quizzes. Okay, so the instructions are there. Joinmyquiz.com and then enter the join code. I think the QR code is a bit too small for you to scan. So just proceed with the URL. Yeah. Okay. Okay, everyone's joining fast. We have 70 plus participants now. 80 already. Very good. What's happening there? Chat, is it? I don't know. Huh? Oh, people joining. We really have 100 plus people here, is it? Oh, okay. Very good, very good. What are those icons you're commenting, right? Padu, macam tu Okay, so we reached 134 participants. 37. Deferred ni. Padu. Okay, you can stop commenting now. I think we need to start. Okay. Oh, banyak sangat ni. Come on, macam live ni. Okay. Okay, okay. We're starting Okay, can you see the questions? Share 3 je. Kau tanya je. Okay. Who's TCK? We wanna find out. Who's TCK? Siapa TCK? First, second, and third, actually tu lah. Okay, first is TCK. Second is, I can't even read the numbers. A something. And third is snags. Siapa tu? Turun bawah. Nak jumpa Prof. Prof ada, Prof nak bagi hadiah. Kupon. TCK A178475. Awak siapa? Oh, GS. Okay, alright. TCK siapa? Oh, wow, so original. TCK siapa? Wah, this is our champion. Tepuk tangan semua. TCK. Okay lah. So, awak duduk sini kejap. Stay here. Nanti kita bincang. Okay lah, I guess that